Determination of volume status in critically ill patients with multiple organ dysfunction and those requiring dialysis is a frequent challenge faced by nephrologists in routine clinical practice. A quick bedside sonographic examination of the lung, inferior vena cava, and the heart provides valuable information when coupled with physical exam findings, vital signs, and other laboratory data. Point-of-care ultrasonography is not meant to replace comprehensive ultrasound imaging, such as obtaining a formal echocardiogram. Rather, it's a complementary diagnostic tool that can help make clinicians more efficient, independent, and more confident in their medical decision making. In this video, I'll give a brief overview of the lung, inferior vena cava, and heart sonography, and try to touch all the common terminology that our ICU doctors use when we are discussing our ICU patients with them. We'll start with the lung ultrasound, and I'll discuss the key concepts of lung sliding, A lines, B lines, pleural effusion, and the use of M mode or the motion mode. Remember, we are not doing the comprehensive lung examination, but it's a quick attempt by the bedside to look at the patient's volume status. Each lung area can be divided into 4 zones by the way of parasternal line, anterior axillary line, and posterior axillary line, and above the nipple line and below the nipple. So you get 4 areas of examination in each lung to perform a quick bedside exam. And the transducer that is used to perform lung exam is usually an abdominal probe or the curvilinear probe. And you can also use a phased array or the cardiac probe. And if your intention is just to examine the lung sliding, you can use a high frequency probe as well. And it's also important to note that lung sonography is essentially an interpretation of the artifacts. Normal lung parenchyma is not visualized as it is filled with air that scatters the ultrasound waves. And in general, the exam begins in the mid-clavicular line in the second or third intercostal space with the probe marker oriented towards patient's head. The transducer is adjusted until a view that includes 2 adjacent ribs like this, and the underlying pleural line and the prominent artifact pattern, either A line pattern or B line pattern, is obtained. We'll see what these are in a bit. This usually requires slowly tilting the transducer until the desired view is acquired. Be mindful of the curvature of the chest wall, adjusting the transducer angle as the exam proceeds laterally to maintain a perpendicular orientation to the pleural surface, because you get best images in grayscale ultrasound when the beam is perpendicular to the organ of interest. So cortex of each rib reflects ultrasound waves and blocks their transmission, resulting in shadows emerging from the ribs. The parietal and visceral pleurae appear as single hyperechoic pleural line. You see this right here? The pleural line with the ribs together appears like a bat. Sometimes that's called a bat sign. It's important to know this because sometimes you'll have hyperechoic lines above the ribs, especially in the patients who are obese, who have a lot of subcutaneous tissue, and you shouldn't confuse that hyperechoic line with the pleural line, which is usually in slightly inferior and in between 2 ribs. And the horizontal lines you are seeing here are called A lines. A stands for air. When the lung is filled with air, that is normal, you find these A lines. Also note that the pleural line will appear as a single hyperechoic structure between the intercostal muscles, and this line will slide or oscillate during respiration, which represents the sliding of the visceral pleura past the parietal pleura and appears as a shimmering effect on the screen, like here. And presence of lung sliding tells us 2 things. One is that pleural surfaces are adjacent, that means there is no air in between, and the lung volume is changing with respiration, which is a good thing. Note that no lung sliding will be observed during breath holding, and absent lung sliding may be seen in pneumothorax and various other pathologies. So again, A lines, these arrows point towards these horizontal lines equidistant from the pleura, and A lines are nothing but reverberation artifacts that arise when the ultrasound beam reflects off the pleura, and rather than entering the ultrasound transducer, partially reflects off the probe and face back to the pleura again before returning finally to the ultrasound transducer. This double length pathway is interpreted and displayed as if the source of reflection lies at twice the distance between pleura and the skin. Multiple reverberations result in multiple A lines, all at multiples of pleural depth. So A lines are normal, and you see A lines when lungs are filled with air. B lines. This is the most important artifact we are looking for in our quick bedside exam when we suspect a patient to be hypervolemic. So B lines are vertical lines and represent thickened interstitium. This thickening could be from fluid or even from fibrosis. And they extend from pleural membrane to the end of the image. This is important to note because sometimes you can see artifacts called comet tail artifacts, which start at the pleural membrane but do not extend through and through. Previously, they used to call B lines as comet tails, but we no longer use that terminology. You just call them B lines. And they move in conjunction with lung sliding with respiration. And they also obliterate A lines. And the number of B lines correlates with the amount of lung water, and patients with decompensated heart failure and pulmonary edema of any etiology, even diffuse pneumonia and pulmonary fibrosis demonstrate diffuse B line patterns. While occasional B lines may be encountered in normal subjects, greater than 3 B lines in a longitudinal plane between two ribs, that is, rib interspace, is considered a positive exam for a B line pattern. And 2 or more positive regions bilaterally constitute a positive exam for interstitial syndrome. So when you have pulmonary edema, you'll see diffuse B lines. But again, if you see 1 B line or occasionally 2 B lines in the posterior regions of the lung when the patient is lying supine, it may not mean anything. So after you are done with the examination of all the lung zones, then you come slightly lower and look at the diaphragm and the area around it. So if there is any pleural effusion, it accumulates in the dependent portions of the lung, so you'll find it above the diaphragm. Like in this picture, you see here, this is the liver, this is the kidney, so this is the right side, and something above the diaphragm is lung tissue. So if there is a black thing here, and you know fluid is black, so it's either pleural effusion or it could be blood in the pleural cavity. And here you can see a pleural effusion with a fibrin plug here. It's a moderate to severe pleural effusion. And here you can see again moderate to severe pleural effusion. And sometimes lung tissue may appear as a solid organ like liver in cases of moderate or large pleural effusions due to atelectasis and consolidation. And here this is the consolidation of the lung you are seeing, and these white things here represent air bronchograms. Now we'll use the M mode for lung ultrasound. So like any other organ, you turn on the motion mode and you bring your line to the area of interest, that is where you see the pleura. And when the lung is visualized in the M mode, the extrapleural structures are stationary related to the transducer and appear as lines parallel to the transducer surface. Those lines that you see on the top of this image. And as the lung expands, alveolar septae and terminal bronchioles within the lung parenchyma move in and out of the ultrasound beam, leading to a speckled appearance, like you see on the bottom here. This combination of solid lines and speckles divided by the pleura gives the appearance of a seashore, where the extrapleural structures are like water in the sea, and the speckled area here represents a sandy beach. This M mode sign corresponds to the presence of lung sliding on B mode imaging. Essentially, you're using M mode to make sure that there is pleural sliding. And this will be really helpful when the pleural sliding is absent rather than when it's present. Like in this picture, you see that pleura is not moving. You don't see any shimmering here. I mean, pleura is moving with the respiration, but not one layer over the other. So there is no lung sliding, and you can confirm this using motion mode, where you can see a linear pattern both above and below the pleural line. And this is analogous to a barcode. Sometimes they call it barcode sign or stratosphere sign. When you see this kind of a mode tracing and not the sandy beach pattern, most likely the lung sliding is absent. And sometimes you can see the differentiation between normal lung and the part of the lung with pneumothorax, because you don't need to have pneumothorax over the entire lung. So for example, here you can see this part of the pleura has sliding. You got these shimmers here, and this part of the pleura is not sliding. So this point here represents the differentiation between the part of the lung with pneumothorax, this one, and the normal lung. That's called lung point sometimes. And use of motion mode here, then you will see like one part of the image has a sandy beach pattern like here, and rest of the M mode tracing would be a barcode pattern. Now we'll talk about the point of care inferior vena cava ultrasound. The diameter of the inferior vena cava decreases with inspiration, and when the negative intrathoracic pressure leads to an increase in right ventricular filling from systemic veins. Inferior vena cava ultrasound provides a semi-quantitative information about right atrial or central venous pressure. In spontaneously breathing patients, IVC diameter of less than 2.1 centimeters that collapses more than 50% with a sniff indicates normal right atrial pressure. That is about 0 to 5 millimeters mercury. And if the inferior vena cava diameter is more than 2.1 centimeters that collapses less than 50% with a sniff, then the patient is assumed to have high right atrial pressure. That is about 10 to 20 millimeters mercury. And if the diameter of the inferior vena cava and the degree of collapsing is somewhere in between, your right atrial pressures are between these two numbers, like 5 and 10. And with positive pressure ventilation, the IVC is commonly dilated and may not collapse at all. And the correlations between IVC dimension and central venous pressure or right atrial pressure in mechanically ventilated patients are weak and inconsistent. And normal diameter of IVC can vary anywhere from 1.5 to 2.4 centimeters. And trained athletes tend to have larger IVC diameters at the upper end of the normal. So where do you measure the diameter of the IVC? And IVC diameter is usually measured in subcostal view with the patient in the supine position at about 2 centimeters from the junction with the right atrium. Like, this is the ideal view of the inferior vena cava in the longitudinal axis, and you have liver on the top of the screen, and this is the IVC, and you see that IVC is entering into the right atrium. You'll also see the hepatic vein joining the IVC. So about 2 centimeters below this junction of IVC with the right atrium, or just slightly inferior to the hepatic vein junction, that is within 2 centimeters of this IVC and hepatic vein junction, we can measure the IVC diameter, and we can see changes with respiration. And it is also important to note that, like, when you are doing serial examinations, you try to measure the IVC diameter at a single point rather than first time measuring it here and second time here and third time here, so that you will have some reproducibility of readings, and then you can change the management decisions. So how do we obtain ultrasound images of the IVC? Some sonographers start by obtaining the transverse view of the IVC by placing the probe in the epigastric region with the indicator pointing toward right. And then they rotate the probe facing patient's head to obtain the longitudinal view. So if you are doing the transverse view in the epigastric region, this is how IVC appears. So IVC is towards the probe indicator because your probe indicator is towards right and IVC is towards right. And aorta you will see slightly towards left, and you see vertebral body and the shadowing from the vertebral body. And IVC is compressible and aorta is usually pulsatile. And I find it easier to obtain longitudinal view directly by placing the probe in the right subcostal region with probe marker pointing towards patient's head. A good view of the inferior vena cava should include liver on the top, and you should see where the IVC is entering the right atrium, like here. And once you find the IVC, ask the patient to take a deep breath as if sniffing a flower to see if the IVC would collapse. In some patients, you'll also be able to see the hepatic vein joining the IVC somewhere here. In this picture also you're able to see, but it's not very clear. And IVC is towards the right and close to the liver and has thin walls, and its diameter changes with respiration. On the other hand, aorta is towards the left and it pulsates. Most of the times it's just hypoechoic and not like really anechoic like IVC. And you'll also be able to see anterior branches of aorta such as celiac and superior mesenteric arteries. And this is how you measure IVC. So once you freeze the image, you measure the anteroposterior diameter at the point of interest, which is, like we talked about 2 centimeters below its junction with the right atrium. And in this patient, it's about 2.3 centimeters, and he's an athlete. And another important thing you want to know when you are measuring the diameter of the IVC is there is something called cylinder effect, where IVC is a 3-dimensional structure, and the routine grayscale ultrasound is a 2-dimensional modality. So whenever we are seeing the IVC in the longitudinal plane, we have to slide the probe slightly to get the longest possible diameter. I mean, the widest possible diameter, because you don't know if you're measuring the diameter here in the center of the circle or towards the wall of IVC. So you might get false underestimation of the diameter if you measure it close to the wall. So it's always good to make it as wider as possible by tilting the probe. To measure the IVC dimensions or changes in diameter with respiration more accurately, you can use the M mode or the motion mode. So you turn on the motion mode, you get a line like this, you get it to the area of interest, which is about 2 centimeters below the right atrium, and you get a tracing. So this represents the inferior vena cava. And once you freeze the image, here you see you measure the widest diameter here, and you measure the smallest diameter here. That way you can exactly get by what percent the IVC is collapsing with respiration. So now we'll briefly talk about the point of care cardiac ultrasound. And it involves demonstration of the common echocardiographic windows, qualitative assessment of the ventricular function, and pericardial effusion. So the probe we use to do cardiac examination, or the cardiac probe, is called phased array probe, and it has a small footprint. Footprint is a part of the probe that comes in contact with the patient's body, and because of the small footprint, you can easily scan in between the ribs and avoid rib shadows while looking at the heart. And it has a probe marker, and the direction of the probe marker differs based on which echocardiographic window you are using. And you can see the curvilinear probe we use to do the abdominal ultrasound. And if you put the curvilinear probe and try to do cardiac ultrasound, you'll get a lot of rib shadowing. So this is the cardiac probe is the ideal one to perform the echocardiography. There are 3 important planes of imaging for the heart. One is sagittal, the other one is transverse, and the other one is coronal. The important thing to note is that heart is aligned slightly oblique when compared to body's long axis. So body's long axis is like this in the vertical region, and the heart is aligned obliquely in this direction. And knowledge of these planes will help you get an idea of what chamber is on the top, what chamber you are viewing in what echocardiographic window. We'll discuss these things in detail in the next slides. So before performing the echocardiogram, adjust the height of the patient's bed and the ultrasound system so that you are in a comfortable position while scanning. And the patient should be supine, and if possible, turn the patient onto their left side for parasternal and apical views. This will bring the heart closer to the chest wall. And if needed, the patient can be supported by placing one or more pillows behind the right shoulder. And also abduct the patient's left arm if the patient is able to follow your instructions. This will open the intercostal spaces. And another important thing to note here is that the probe marker is on the right side of the screen. This is opposite to the abdominal exam we just did, where the probe marker is on the left side of the screen. This is just a cardiac convention, and it's important to know because whenever we are discussing different cardiac windows, we say probe has to point in one particular direction. But if your probe marker or the screen indicator is in the opposite direction, if the machine is in the abdominal mode and the indicator is on the left, then you have to do the opposite thing. For example, say we are doing a parasternal long axis view, then we say that the probe marker should point towards patient's right shoulder. But if the indicator is on the opposite side, then you make the probe marker towards patient's left hip. So essentially you're just doing the opposite thing. But instead of all these things, it's always better to set the machine to appropriate organ you are imaging. If you are doing a cardiac exam, just set it to cardiac mode and pay attention to which side the screen indicator is located. So the first one is the parasternal long axis, and for this view, the transducer is placed in the 3rd to 5th intercostal space immediately to the left of the sternum, and transducer orientation marker is pointing towards patient's right shoulder, the 10 o'clock direction. And you'll get a picture like this. It's nicely represented here. So the part of the heart that is closer to the probe is on the top of the screen, and that is a part of the right ventricle and right ventricular outflow tract. And then you will see the left ventricle, left ventricular outflow tract, aortic wall, mitral wall, and left atrium. So this is how a parasternal long axis view should look like. And mitral wall should be in the middle of the screen. If the wall is off center, tilt the transducer away from the sternum, and then you'll get a better view. And interventricular septum and left ventricular wall are parallel and as horizontal as possible to get the best view. And parasternal view, long axis view, is a good view to assess left ventricular size and function, and if there is any pericardial effusion. And it is also one of the easiest views to obtain. So this is the most commonly performed view when you're doing the bedside echocardiogram to get quick information. So after obtaining the parasternal long axis view, from that position, rotate the transducer 90 degrees clockwise to obtain the parasternal short axis view. And transducer orientation marker is pointing towards patient's left shoulder or the 2 o'clock position. Tilt the transducer face slightly upward toward the patient's right shoulder to get aortic valve in the view. Here you see the middle one, the aortic valve with 3 cusps you are seeing, and that's when you tilt the probe towards patient's head or towards the base of the heart. And if you turn the probe downwards, you will see mitral wall. That view is here. You see the mitral wall. Sometimes this is called like fish mouth appearance. That you will see when the probe is perpendicular to the chest wall. And when you go further down towards apex, you will see the papillary muscles right here. And you see this left ventricle is nice and round. Sometimes it's compared to a donut. And here is the right ventricle. So in parasternal short axis view, you have circular left ventricle and a semicircular kind of or D-shaped right ventricle. This is a good view for the assessment of left ventricular systolic function and segmental wall motion abnormalities. And this is also a good view when you're looking at D sign to suggest right ventricular dilatation. We'll see the D sign in the next slide. In this view also you'll be able to see pericardial effusion. So, and this is another easy way because you're just tilting the probe from the parasternal long axis. And now the apical four-chamber view. So from parasternal short axis window, come down straight, maybe on an imaginary line from right shoulder to parasternal short axis position till anterior axillary line. And for this position, 30 to 40 degree left lateral decubitus position might help, so that you can put one or two pillows on below the right shoulder. And now tilt up, look towards the base of the heart till you see all four chambers, and the long axis of the heart is vertical. And that would be the best image when the long axis of the heart is vertical. And the orientation marker is towards left axilla, and pretty much same direction as like the how you do parasternal short axis. And if you further face up, you will see aortic valve in the middle and foreshortening of the LV and RV. Sometimes it's called five-chamber view, but for a quick exam, as long as you get a good four-chamber view, that's good enough. And if the heart appears tilted to the right, you are too medial, and then move your transducer laterally. And this view is useful for ventricular relative size. Usually right ventricular size is less than 2/3 of left ventricle, and is also a good view to look for ventricular contractility and if there is any pleural effusion. This is another window commonly used to look at the heart. This is subcostal view, and the transducer is placed in the subxiphoid region with the orientation marker towards patient's left. And the probe should be as parallel to the body as surface. You can apply gentle pressure like this, and what you'll see is the left atrium, right ventricle, left ventricle. It's similar to apical four-chamber view, but slightly tilted, and you are using liver as your acoustic window. And sometimes this view can be tough because of the bowel gas. So we mostly rely on parasternal long axis to get a quick look at the heart. And this view is especially useful for ER physicians and intensivists to examine the heart while CPR is in progress. So how do we estimate left ventricular ejection fraction? So essentially it's done by eyeball method. So it's depends upon the operator's experience on how many normally functioning ventricles they saw and how many abnormally functioning ventricles they saw. And here in the left picture, you see normally contracting left ventricle. And in normal contraction, the walls thicken and move towards the center of the LV symmetrically. And also note the difference in the LV size between systole and diastole. And also note these mitral wall leaflets. The anterior leaflet of the mitral wall is approaching the septum. That's how it should be. And in the second picture, this is a parasternal short axis view. You're seeing that this left ventricle is not contracting as it should. So there is definitely some systolic dysfunction. And here in this picture, another parasternal long, you see that ventricle is pretty much not contracting, and the mitral wall leaflets are like barely moving. So this is severe systolic dysfunction of the left ventricle. And as the experience increases, we can identify more intermediate stages. And this is an example of a hyperdynamic left ventricle where the patient is most likely volume depleted. And here you can see small amount of pericardial effusion. Effusion or fluid is black, right? So you can see some fluid around here. But again, the patient most likely needs fluids. So we'll see the use of M mode for semi-quantitative estimation of left ventricular systolic function. So the eyeball method that we saw previously was essentially a qualitative assessment, and now the M mode would provide us semi-quantitative assessment. M mode to look at the excursion of mitral wall leaflets is typically performed in parasternal long axis view, and it can also be done in parasternal short axis view if you want to look at the whole left ventricular diameter change. But parasternal long is commonly used, and mitral walls are the things that we look at. First of all, we need to get a good grayscale image of the parasternal view, and then you turn on the motion mode and bring the motion mode cursor to the tip of the mitral walls. And once you do that, you get a tracing like this. This M-shaped tracing here is the motion of the anterior mitral valve leaflet, and this part here is a septum, and here you see the mirror image that represents posterior mitral valve leaflet motion. And the first peak of the M is called E wave, and it represents early diastolic filling of the left ventricle. And the late peak, or A wave, represents active filling from atrial contraction. The distance between tip of the mitral valve E wave to the septum here is called E-point septal separation, or EPSS. Normal EPSS is less than 7 millimeters, like this. I mean, pretty much it may be around like a millimeter or two here. And an EPSS more than 7 millimeters may be associated with left ventricular systolic dysfunction, because the reduced stroke volume results in a decrease in amount of blood moving through the mitral valve in early diastole. That's the purpose we are looking at mitral valve. If your ejection has reduced, you have more blood in the ventricle, and you have ultimately less blood flow through the mitral valve. But be cautious, because it may also be seen with the dilated LV, aortic regurgitation, and mitral stenosis. In these conditions, EPSS may be more than 7 millimeters. So interpret in the right clinical context. And here in this picture, you see right ventricular dilatation. This is also a qualitative assessment, essentially. We said right ventricular diameter should be less than 2/3 of left ventricle. Here it's labeled as right. Don't pay attention to this green marker. It's messed up. Ideally, it's supposed to be here. And here the right ventricle is more than 2/3 of left ventricle. And here is an example of D sign, where you see there is right ventricular pressure overload. And normally in the parasternal short axis view, which is this view, we were supposed to see a nice circular donut-like left ventricle. But here you are seeing this ventricle, left ventricle has become like a D and not circular anymore. That's why it's called D sign. And this might be indicative of pulmonary embolism. And the next thing that you are looking for is pericardial effusion, especially in our uremic population. You might want to see what's the extent of pericardial effusion. You might also want to assess by the bedside, like you dialyze the patient for like a week in a row or 2 weeks in a row, and then you want to see if the size has decreased or not. So essentially, in this parasternal long axis view, this black thing surrounding the heart represents pericardial fluid. And here, this part here is descending aorta transverse section. And one thing to remember is that anything that is posterior to the descending aorta, meaning here, any black thing or fluid would be pleural effusion. Anything that is anterior to the descending aorta or at the descending aorta level, that most likely corresponds to pericardial effusion. So, I mean, it's likely that patients have both pericardial and pleural effusion in the setting of volume overload. So you can see both here, like you see here, you see pleural effusion and also the pericardial effusion surrounding the heart. And I mean, if you really want to get some semi-quantitative idea, any pericardial effusion with less than 5 millimeters of pericardial separation in diastole is defined as minimal. And 5 to 10 millimeters of separation is small and may be corresponding to 100 to 250 cc. And 10 to 20 millimeters of separation is moderate, corresponding to a fluid volume of approximately 250 to 500. And greater than 20 millimeters separation is considered to be large, which corresponds to a fluid volume greater than 500 ml. So now we briefly discussed IVC, lung, and heart ultrasound. So taking together all these things, what's the likely volume status of this patient? Here, this is the IVC ultrasound. This is the heart, parasternal short axis view, and this is the lung. So in IVC, what are you seeing? IVC is completely collapsing with respiration. I mean, it could be normal finding, but it might point towards hypovolemia in the right clinical setting. And in the parasternal short axis view, you see that left ventricle is almost collapsing. So this is hyperdynamic left ventricle. And here in the lung ultrasound, you see A lines, that is horizontal lines, which represent air in the lung and not fluid. So taken together with hyperdynamic left ventricle completely collapsing IVC and A lines in the lung, most likely suggest hypovolemia if your clinical picture correlates. And how about this patient? So here you see IVC ultrasound, heart, and the lung. In the IVC, you see very prominent hepatic vein, and with respiration, it's not doing anything. It's not changing at all with respiration. And here in the heart, you see the left ventricle is not moving together with the heartbeat, and you see these mitral wall leaflets are just barely moving. So there is severe systolic dysfunction. And here you see B lines, nice vertical lines extending from pleura to the bottom of the screen. Those are moving with respiration, so which indicate fluid in the lung. So taken together, this suggests that the patient has severe congestive heart failure with pulmonary edema, and this patient would benefit from diuretic therapy or ultrafiltration. And that's all I got for now, and thank you.